Good day. This is Charles Denham. I'm chairman of TMIT, and we want to welcome you to the webinar entitled Engaging, Activating, and Partnering with Patients and Families. It's part of a four-part series that we are hosting, and it's a real honor to have a terrific team. Today we're going to have a fast-paced environmental scan of the area with some great experts and leaders and reactors across our nation. I am on the third slide and just want to remind all attendees to make sure to turn up your volume on your computer, and if you continue to have problems with audio, click on the request phone area on the lower left-hand side of your WebEx presentation screen. I'm on slide 4 now, and just want to remind those that do not have slides to go to safetyleaders.org, www.safetyleaders.org, and click in the upper right-hand menu panel on March 17th, and you'll be able to download the slides. The next slide just shows where those slides will be, and I want to remind all attendees that we will have a transcript and then audio linked to the slides within 3 business days on the web. So by next week, this will be available at the same site. Our next slide, slide 6, is a disclosure statement. Please read it carefully. We have some great speakers today. I will not read it, but all of the declarations of the disclosure statement are in full there. And we certify that no funder or educational grantor has had any influence over what is delivered. Our mission is to save lives, save money, and build value in the communities we serve. And this webinar series really addresses that, the simultaneous sort of focus. And we're so honored to have leaders from the Centers for Medicare and Medicaid, also leaders from our organizations across the country, many well-known, many are frontline. But what we always do is we always start our webinars with the voice of the patient and family, and this is much more than symbolic and very special regarding this webinar. We have Steve Rell, father of Braxton Rell, and on our next slide, slide 9, you have a picture of Braxton, who Steve lost recently. Steve, could you open us with just a word from patients and families, and then we'll get started.
Yes, Chuck. Thank you. Good day. I would like to thank everyone who has taken time out of your day to join us in saving lives. My family came to join the patient safety movement out of tragedy. On December 13th, 2008, our lives were shattered. And we wondered, how could a normal, healthy little boy who could stand in front of a hockey net and stop shot after shot and finish a game with a shutout, then go out and skate the next game and score a hat trick? When told how great he played, would just bow his head and just smile. We would have never thought in a million years we could lose our son. Braxton would never accept praises for win or loss, winning or losing. He was a team player. So I ask, how could a team of healthcare providers in the largest hospital in our state make such simple yet critical mistakes to take Braxton's life? When Braxton died, all lines of communications were cut and all doors were slammed shut. No one was there to say they were sorry or help us try to figure out what went wrong. If there would have been communication, Braxton's death could have been handled a lot easier for us, and we would have been able to handle his death easier. It's been 2 years now, and we still have no answer. So I would like to thank you and ask you to please help us engage patients and families. Thank you.
Thank you so much, Steve, and thank you for the commitment that you've made to really help hospitals understand how important it is just to reach out and have the communication and how easy that it really can be. But it is tough and it requires great courage. Our speaker panelists, I'm going to introduce each one by one on the next slide 10. We have them, but in order to give them more time, I'll introduce each one of them as we go through. We have Joe McCannon. Many of us have worked with Joe for years and years in the quality quality and safety movement, and now we all have the honor of having Joe be one of our leaders at the Centers for Medicare and Medicaid with Dr. Don Berwick, and in personal experience from seeing the frameworks and the leaders that they're engaging and putting into action. It's just such an honor to have Joe take a few minutes to share the vision and the latest update with us. Joe, would you please?
Chuck, thanks so much, and as always for creating this forum and this opportunity to speak with you all. I think that we really appreciate it, and I don't want to say too much other than to just give a little framing for the conversation today and talk a little bit about where we are at CMS at this stage. Before I do that, though, I would be remiss if I didn't just pause for a moment and also say thank you very much to Mr. Rell for sharing with us Braxton's story, the incredible pain and hurt that you all have experienced and are probably still experiencing is very difficult to fathom. But I know for us here at CMS and for all of our colleagues, you return us to the reason that we do this work every day, so that families don't have to experience what you've experienced, and so that we can create a future where that kind of harm and that kind of unnecessary loss won't happen again. So thank you very, very much. With sort of Braxton's story as a backdrop, I just would want to return everyone on the line to what we're outlining as our goals and objectives overall at CMS at this stage. What we're trying to create is an idealized system, a future system that really meets three objectives for the United States, for our beneficiaries, but really for all Americans. First, a system that creates great health in the population, that focuses on determinants of health and makes sure that we're as healthy as we can be at all times. Secondly, a system that focuses on having the highest quality of care possible, that's safe and timely, effective, efficient, equitable, and patient-centered. That this vision of what care can be is actually something that we realize in every facility around the country, in every care setting on a daily basis. And then third, a system where we're able to first control and I think ultimately reduce costs through improvement. By getting better, we know that we can save money, and we know that saving money means that we can make additional improvements within the healthcare system and in other social sectors that are so severely in need of funds at this stage. So with that, I would just say that we are every day here at CMS reorienting ourselves to that goal and to that mission, making sure that that mission is reflected in all of our programs and all of our activities, making sure that we return to it and return again to the patients and families like Braxton's families who have been so burdened by the fact that we don't quite yet have that optimal system that we want to create. Specifically, as we come out of the gates here in the new year and think about the direction that we want to take, we're focusing on patient safety. And we're focusing on care transitions, reducing those complications that can really make the transition between care settings so fraught. We're focusing on those areas because we know that those are areas where we've seen great promising examples of success. There are terrific pockets, but we want to make that promise ubiquitous, and we want to make that change national. And so right now our thinking and our planning is in preparation for redoubling our efforts on safety and care transitions in the very near term. There's certainly a lot of programmatic activity, policy activity that's well aligned with safety and quality, but we want to even amplify that here in the very short term. I would just say, specifically with respect to today's topic on this call and patient safety in particular, that this is an area where we have great opportunity and a great potential for change. If we're talking about patient safety as an example, improving care transitions as an example, these areas where we're beginning our work, we know that engagements of patient and families is not just a nice to have, not just something we should think about, but actually totally central to doing this work right and to transforming care in the way that we want to transform it. Part of our job here is to raise awareness so that people understand that care is not always reliable. They understand that it might not always be safe, and they can engage and become more activated participants in the care process. Part of it is actually making sure that they are in the room as we redesign care so that we understand their experience and learn from their frustrations and learn from their fears so that we can create designs that create the most safety and the highest effectiveness possible. And then part of it is, I think, making sure that we use patients and families as helpers in the process, very active helpers who can let us know about more about themselves and their preferences and their needs, who can track the care process through better discharge planning and medication cards and things of that sort. So I think we've got a tremendous opportunity here, and it's one we're looking forward to seizing in all of the work we're going to be doing at CMS, and for that reason I'm excited about the ground you're going to be covering here today. Thank you again, Chuck, for the opportunity. Thank you to everyone on the line for redoubling their efforts in pursuit of this three-part aim and in pursuit of improving patient safety and care transitions in particular.
Joe, thank you very much, and also thank you for allowing your speakers and the program design of the sessions for the QIOs and the ESRD networks to really focus on both boards and engagement of patients and families. Without the leadership to focus on it, we wouldn't have this webinar, and we want to thank you for that. And that allows us to transition to the acting Chief Medical Officer of CMS, Dr. Paul Magana, geriatrician, and also behind that meeting, which I'll show one slide of here shortly. Paul, we know you're at another major meeting. Would you share with us your message and your new position, taking the helm from Barry Straub and focusing on this area, especially patients and families?
So I wanted, too, to start by thanking Steve and all the other patients and families who are joining with us in this effort. Unfortunately, there are way too many people who've been harmed by our healthcare system, and it is hard for people to step forward and say these things because most of the errors that happen are happened by well-intentioned providers. But I just want to say how grateful we are to them for finding the courage, even in their loss, to step forward and share this information with us. I also want to thank the QIO community and the ESRD network community for joining together. This is a second in a series of 4 webinars. Last time we talked about leadership and the boardroom and governance, and I think these two topics, although they seem different at first, are actually very much related. And I would make 3 points, Chuck, to the audience today. The first one Joe has covered very adequately, and that is the principal reason for bringing patients and families into this discussion is because that's where the information is and that's where the solutions are that will help us to solve patient safety problems. And so we get good information from them, we get the best information from them, and I think that's the fundamental reason for bringing them in. Now at CMS, since Don Berwick's taken over at the agency, we've made deliberate efforts to try to model this and to try to change what we do and bring patients and families and their stories to us. Those of you who attended QualityNet at the end of 2010 saw that each of the 3 plenary sessions each day started and involved patient stories. So we think that this is the right way to go. Like Joe, we think it's an essential way to go. We're also continuing that in our daily work here at CMS. So just in the last week, we've had 3 patients come into the agency, 2 of whom met directly with the administrator in sessions on how to redesign our sessions. And you're going to be hearing later from the director of the QIO program and ESRD network, Moody Williams, and I'm sure she'll be mentioning some of the information that we learned from those direct sessions in Baltimore in the agency where for the first time in many years we're getting patients to come in and teach us everything they know. The other 2 points I wanted to end with, Chuck, are that there's 2 other good reasons to do this, and there's 2 other good reasons that I think will make the QIOs much more effective in their work going forward, as well as the ESRD networks. And that is having patients in the room makes things real and brings energy. It brings energy to the discussion, it brings relevance and authenticity, and we think it'll make your work far more powerful and far more effective going forward. And the thing that you're always left with, and it happened to us this week with the patients that came in to talk to the administrator, is that we all come away with a renewed sense of purpose in our jobs and a sense of urgency that the time to act is now. It has been more than 10 years since the IOM first report on this, and it's even longer since the first pioneers in patient safety have published papers on this, and there is an urgency, and I can think of no more effective or better way to do it than to bring patients into our sessions and with our providers and sharing their knowledge with us. And that really brings me, Chuck, to the end with the loop to our last webinar on leadership in the boardroom. We would also ask the QAOs to do what they can to have patients, families, and their stories not just brought to their quality improvement work, but brought into the leadership and governance in the boardroom as well. Because these same powerful effects that we've been talking about in the last couple of minutes, the best information possible, the high energy and the sense of urgency can be brought directly to the leaders of healthcare organizations, hospitals, and others by bringing patients and their families directly into the boardroom. So those were my comments, Chuck. I congratulate and thank you for helping us get this information out to the QIO and ESRD network communities, and wish you really good luck on this powerful and fast-moving session.
And thank you very much, Paul. There is no more dedicated set of leaders than Paul and Jean Moody Williams, who we'll hear from next, and Dennis Wagner, who is not on this call, and Joe Magana. I frequently have calls late in the evening and on weekends with them. They are very dedicated to quality improvement, and we're very grateful. And Paul, I know you won't be able to stay perhaps for the Q&A, but let me represent the thanks of all of us for the terrific job that you're doing with a daunting task. I'd like to move to Jean Moody Williams and ask her to give us her update perspective with the dimension of patients and families, and including them in the quality improvement approaches that the QIOs and ERSD networks can tackle. And I'm sure that message goes much broader to our network of safety officers and leaders across the country. Jean?
Thanks so much, and again, I add my thanks to everyone, including the patients, the QIOs, the ERCD networks, and all leaders that have joined us on this call. For a number of years, we've always had a mechanism of hearing from our beneficiaries and patients through formal processes. We've had what we call beneficiary protection or beneficiary-centered theme, in which the QIOs receive complaints written complaints usually from our patients, or we're in the midst of an appeal and somebody might be being discharged from a service that they think might be premature or not being admitted to an emergency department. In the ESRD arena, we have a mechanism for receiving complaints and grievances, but oftentimes these types of communications occur during the time of a crisis or when there's grief involved or in the midst of an era. We want to change that paradigm where we're not reacting, but instead we're being much more proactive in our approach to how we incorporate feedback from our customers, our patients, into all of our processes, into the policies that we make, into the decisions that we make. We want to change the way we think before an incident occurs. What can we do better? How can we hear from the patient's voice to tell us how we might improve our system? We also want to hear not only what's not working, but more actively seek out those things that are working. How do we spread those things from one facility or provider to another? If we figured it out in one part of the country and we've engaged patients, let's share that so that we can all learn from those activities of what's actually working. The other thing I think we have to work on is how to make this exchange of information more comfortable. Not comfortable in the sense that we don't want to tackle the hard issues, but comfortable in the sense that we feel free to address the hard issues, that we feel free to discuss those things that are most on our mind, and getting some of that awkwardness of the interactions when we have policymakers, providers, and our patients all together in the same room. How do we work past that? And I think that we'll hear from our presenters today some very innovative things in that arena. And just lastly, I'll say, as Paul alluded to, we are practicing what we preach here. Just already twice in the past week, we've brought patients into the boardroom, into our conference rooms, and it really, really changed the dynamic when we had a patient and several talk about those things that are really important to them, directly to the administrator, directly to the senior policy officials. And primarily the thing that we heard over and over again is, support me when I need you, to listen to what I have to say, treat me as a whole. We had an ERCD patient that said, I'm bigger than my kidney. I want you to see me in my totality. I want care that works. I want convenience and comfort, and I want to be a part of the education so that I understand what I need to do to be able to participate in my care more directly. This information is so much more powerful when it's spoken from the words of the patients rather than the secondhand message. So I again applaud this work. I'm so excited about the direction that we're going in, and I think this will be a great opportunity. Thank you.
And Jean, is it fair to say that we'll see more specifics regarding engaging patients and families, that we can count on that as something that is going to stand the test of time?
Absolutely. We're working together in many sectors here to come up to shape what that will look like here and what's most effective to address the needs.
Great. Thank you so much, Jean. I'm going to move quickly through my deck. We're about 5 minutes behind our flight plan, and I want to make sure to give everybody as much time as possible. I am, again, wanting to remind everyone you can download the slides from safetyleaders.org. I'm on slide 15, and the point that we are making in the National Quality Forum Safe Practices and other areas that we've been working in is that patient and family input can formally be structured at each level of the leadership system of a hospital or an outpatient clinic or a dialysis clinic, from the governance board to from the top right to the bottom, and we will hear that and see that, and we provide that slide for that discussion. Again, the next slide, 16, is just to remind everyone the conference that led to this series, and that the slide is there to be able to go back and look at that content. The next slide is, again, a reminder that you can now go to our website at the link at the bottom of the slide and hear Dr. Don Berwick's Inspirational Open, and we are gradually putting virtually every one of these sessions up on the website that can be listened to and have the slides tied to. Story power is absolutely critical. We heard the Braxton Rells story. Dennis Quaid is absolutely committed to the mission. Right now we're shooting the next documentary in a series of documentaries addressing how to use stories and story power to have an impact. And in our last webinar, I just remind us that of the Heath and Heath message that really the conscious mind is like the rider of an elephant, but the heart is the elephant that moves things, and that the path that we need to guide ourselves down is a new path, so that the rider, the elephant, and the path are the metaphor of the conscious mind, the heart, and what really motivates us to move, and that we need to design a new path to engage the heart and the mind to move the hands to action. The next slide just is a reminder that the Transitions in Care Day that was led by CMS has now been entirely produced by TMIT, free for everybody to use, and you can log on the website to be able to follow that. And as I close my comments, we've found at TMIT that the real high-performance care is at the intersection of engaged leaders, practices that deliver predictable outcomes, and technologies. In the engagement of patients and families, the technology may not be a widget, software, or imaging or something like that. The technology really is the methodology of implementing and being able to use tools and create new tools to be able to engage the leaders and really get patients and family stories involved. I remind you of Ashish Jha's great work on board chairs, and this ties to our last webinar, that 10% of the bottom bottom in quality across the country. Of 1,000 boards that were interviewed, did not think that they were below average. But I think that all of us are below average in how we can engage patients and families. We have the Safe Practice, and I'll be coming to Dr. Burston. I believe I'm just watching to see if she'll be on the phone today. If she isn't, I'll cover the area with the NQF Safe Practices. But I draw your attention to this set of national standards of the safe practice for culture and leadership structures. If we look at the 6 national priorities of the National Priority Partnership, patient and family engagement is one of those. It's cited in this national standard. We address directly in this national standard that is being tied to payment across the country that direct patient input is a requirement, that a structure and system needs to be established to obtain direct feedback from patients about performance of the organization, that satisfaction surveys are absolutely not enough, and that patients and families representing the population should not only be included in educational meetings, but should participate in formal committees that provide input to the leadership of management of safety and quality. And I want to thank those that are in attendance that are not speaking today, but Dennis Quaid, Nancy Conrad, the wife of our 3rd astronaut who walked on the moon, and a number of our patient advocates here who are co-authors of the chapter of this national standard. And Dr. Helen Burston, who couldn't be with us today, created the opening for us in the National Quality Forum Safe Practices to then have this group of authors, Jennifer Digman, Mary Foley, Dan Ford, Becky Martins, Patty O'Regan, Dennis Quaid, Arlene Salamandro, and Sue Sheridan, who will speak today, all to be co-authors. They also, most of this group were co-authors on a peer review article, an original article in the Journal of Patient Safety that addressed active listening and communication breakdowns between patients, families, caregivers, and leaders. And finally, that you can get this set of practices from the National Quality Forum website, and we provide that to you. We also address the fact that we're building impact calculators to integrate clinical, operational, and financial performance that include engaging patients and families, and that we have a number of toolboxes, and I'm clicking through the slides quickly to let the rest of our speakers speak, but that you can find that on safetyleaders.org. And the Chasing Zero documentary that showcased Steve Rell and Sue Sheridan's story now has over 3.5 hours of content, video, articles, and a number of tools that will be updated there. There also is a set of content from the Global Patient Safety Summit that was held in Nice, France, and that content is available. And also content will be available in a focused grassroots effort on patients and families called Care Moms. So the webinars and workshops and these assets are all available on safetyleaders.org. That's slide 38. I'd like to come to Helen Burston, and I don't believe Dr. Burston was able to make it with a conflict at the National Quality Forum, but I just want to say and thank Dr. Burston for creating the clearing for us at the National Quality Forum to actually have the specifications that the QIOs can follow and leadership teams can follow that are explicit and specific specifications that I know payers are beginning to tie payment to assure that patients and families are engaged. I'd like to hand over the mic now to Maureen Connor. Maureen will tell the Dana-Farber story and the fact that she's now moved from Dana-Farber, one of our leaders in paving the way to engage patients and families and have the best practices that they can share with us, and also the perspective that now she has moving to another center where she can implement these programs. Maureen, we're really pleased and privileged to have you speak to us today.
Thank you, Chuck, and thank you so much for inviting me to participate in this webinar. By way of background, in 1997, there was a high level of executive leadership commitment to advancing patient and family-centered care at the Dana-Farber Cancer Institute. This partnership with patients and families actually began shortly before Dana-Farber inpatient beds were moved to the Brigham and Women's Hospital, connected by indoor walkways. In terms of getting started, leaders were able to capture patients' and family members' perspectives through a series of town meetings. And during these town meetings, a lot of concern and anger was expressed about the potential impact on the quality of care with this bed move. So over time, by listening and engaging patients and families in the planning process, a trusting relationship was developed to the point where on the day of the bed move, patients and families actually helped transfer patients and equipment over to the Brigham. Interestingly, patients and families also conducted post-move rounds. They actually went into each patient's room at the Brigham on the newly designed unit, asking them, are we meeting your needs? Do you have any problems? They then summarized these findings and reported them to the inpatient leaders. In terms of further developments, the Adult Patient and Family Advisory Council was created about a year later in 1998, and the Pediatric Council 1 year following that. Both councils report to the board through the quality improvement structure, and the adult co-chairs are patients and or family members, whereas for the Pediatric Council, the co-chairs are a family member and a staff member. The councils are well embedded into the organizational structure at Dana-Farber, and for each quality improvement committee, there is at least one patient and or family member in attendance. In fact, a quality improvement initiative does not occur at the Dana-Farber unless the question is first asked, do we have a patient or family member to join us? They also serve as members of the board-level quality committee, and this is the committee where Sentinel events are presented. And here it is the council co-chairs who attend this meeting. I'll never forget, one aha moment for all of us was when one of our patient advisors from the Adult Council spoke up during a conversation about hand hygiene and said, listen, I don't want to be reminding staff to wash their hands. It is the clinician's responsibility to do this, and it really made us think about some of the programs in place. Council members serve on a multitude of committees, task forces, and teams. They're also well integrated into volunteer services. In fact, the Director of Volunteer Services also oversees the Center for Patients and Families. There are a number of projects and initiatives that have occurred, and this is just a very small sample that I'd briefly like to highlight. Working on the wait, patients and families have been intimately involved in many wait time initiatives, hand hygiene campaign. Each year there's a QI team that's put together with patient and family representatives from the councils. And 1 year the patients wanted to have posters with pictures of patients and their favorite clinicians. So you can see the poster here, All Hands to the Pump is one example. New building, a brand new oncology ambulatory building just opened this spring, and patients and family members were involved from the very beginning to the point where they helped to select the architect. Care improvement team, this is an inpatient team reviewing patient satisfaction survey findings, discharge telephone call findings, et cetera. Rounding, I gave one example of rounding in the bed move story, and there have been other rounding initiatives. We received funding from the National Patient Safety Foundation and Commonwealth Fund to conduct a study where we had patient advisors in the clinics asking other patients about safety concerns, and this work was published, and the references at the end of these slides. Also, the healing environments, a lot of work went into that, satellite clinics, the expansion of oncology care into the community, patients and families, again, very much involved. One of my favorite examples of an initiative occurred with our Pediatric Patient and Family Advisory Council. This was their very first initiative, and they expressed concern about patients with fever and neutropenia going to the emergency room at Children's and sitting in the waiting room and potentially being exposed to others with undiagnosed cases of communicable illnesses. So in partnership with the Pediatric Clinic at Dana-Farber and the leaders in the ED at Children's, they actually established a fast-track process where children would go to the ED, be placed in a private room, would avoid being in the waiting room. And on the next slide, I can show you that this is a sample of an orange plastic placard that parents put on their dashboard so they can pull right up to the ED. They don't have to go to the garage across the street until they're ready to do so. And this has been a highly successful program. On the next slide, I have a copy of When Things Go Wrong, Responding to Adverse Events. This was published some time ago, and of course it relates to disclosure of medical errors. It was done under the leadership of Dr. Lucian Leap, and I was privileged to be able to invite two of our council members, Mary Dana Gershinoff and Gary Jernigan, whose names are listed as members of the Full Disclosure Working Group. Teamwork training. I'd like to spend a minute on this initiative. This initiative was undertaken under the leadership of Dr. Saul Weingart, who oversees the Center for Patient Safety at the Dana-Farber. And it was really a campaign rather than an educational program or research where the team focused on hazards rather than skills. So in other words, we wanted patients to be aware of any changes in their chemotherapy, last-minute changes in orders, hand hygiene, and so on. And the real emphasis was to bring messages to the patient. It, in essence, was empowerment without obligation and called the You Can campaign. Check, ask, notify. Check based on situational awareness. Does your chemotherapy look like it's a different color this time? Ask, appropriate assertiveness. Debriefing. Patients were instructed to bring a list of questions, concerns to the next clinic appointments. And on the next couple of slides, you can see samples of materials. These materials you can feel free to reproduce as long as you acknowledge the Dana-Farber Cancer Institute. And a paper was published on this work. Again, the reference is included at the end of the slides. This slide just lists some of the activities around the You Can campaign. And the next slide, I'd just like to share with you a bit of data. Several questions here. Would you notice if the color of your chemotherapy or pills were different than usual? Would you feel comfortable asking your doctor or nurse if they wash their hands? Did the nurse tell you what to expect during your last treatment? You can see that there's no real difference between the baseline survey and follow-up. Awareness of and impact of the campaign, about 32% of patients were aware of the campaign. And interestingly, 39% of those aware of the campaign said that it changed their behavior. However, this was not corroborated in the findings that I just described. We thought that there may be several reasons for this. One, the number was very low in terms of the participants surveyed. Also, participants may not have had an opportunity to try out some of these new skills and so forth. I'd now like to shift gears just a little bit to the North Shore Medical Center where I'm currently working and talk a little bit about the power of one. By the power of one, I mean one unit, one nurse, one team. And at North Shore, they established a Patient and Family Advisory Council last year. So being relatively new here, I've been doing my own informal survey of how patient and family-centered care has been implemented within this organization. And much to my amazement, I have just seen some exciting work going on in a number of units. In both the intensive care unit and the cardiac surgical unit, they have patients and family members included in bedside rounds. They do not have visiting restrictions for family members. And as we all know, family members are not visitors. They've implemented TCAB on several med-surg units, and it's so exciting to see the partnership with patients and families, in one instance on a delirium project, and care plans for pain, so that the patient is interacting with the nurse and really helping to create that unique care plan, very much with the patient's input. I mention this because for those of you just starting out, I think it's critical to do some type of assessment. And I do firmly believe from the years I've been involved in this work that patient and family-centered care does exist in every organization in the country at one level or another. And I just think it's really important to recognize the good work that's being done. The NQF Safe Practices, I think that Dr. Denham touched upon this, so I'm just going to move to my last slide. And I would just like to leave you with one thought: nothing about me without me. Thank you.
Thank you so much, Maureen. We really appreciate your insights there. And when we get to the Q&A, I'm sure that we'll have additional questions that folks will have, because you've seen two sides. You've seen what what you can do and what has been done at Dana-Farber, and also perhaps the learnings that came after the accident of Betsy Lehman and how that helped drive change. It's a real honor to now introduce Dr. Farris to Mimi. We had the opportunity of shooting video of him leading their patient and family work at the Mayo Clinic in Rochester, and more dedicated champion for this we would not know, and I think that his perspective along the journey can give us some insights. We know Dana-Farber has kind of led the way for all of us, and Dr. Tamimi, we'd like to hear about the Rochester experience.
Well, Chuck, thank you so much, and thank you for the opportunity to present, and thank you to all the attendees who have taken an interest into the patients and their families who've shared their stories with us. What I would like to do in the next 8 to 10 minutes is share with you 4 key things. First of all, I want to share with you the journey we've taken over the last few years, moving from a handful of patient family advisory councils to over 20 to improve safety and satisfaction. I want to share with you 3 key lessons we've learned during that process, the pragmatic application we've used to try to achieve that, and close with some action steps for those of you who don't currently have PFACs. So first of all, I want to start with the journey we took, how we got there. And honestly, I think it reflected the overlap of 4 key factors. First of all, as in many healthcare institutions, this is core to our primary value of the Mayo Clinic. The needs of the patient come first. But beyond that, there's been a recent institutional focus on satisfaction data, particularly the PRC data. And for those of you who aren't familiar, PRC is an external survey that's conducted of 75 patients per care unit, looking at retention and re-referral rates. And institutionally, we were looking at means of trying to improve that satisfaction and retention rate. At the same time, there were several divisions at the clinic who were in the process of applying for the Minnesota Quality Award, which is a state version of the Baldrige Award. And it was felt that patient-family-centered care and patient partnership would address Category 3 in the Baldrige criteria, the voice of the patient, the voice of the consumer. And finally, and I would stress the utility of this, I think it was the frank recognition that nearly 3/4 of the HCAP survey questions either directly or indirectly address communication skills of providers. We were looking at means of trying to incorporate policy procedure alterations that enhance our capacity to address those needs. Now, I share this with you for 2 reasons. One, to provide overview of how pressing the problem, at least in my mind, clearly is. And 2, to share that it applies to all members of the healthcare team. This is a time motion analysis of 2,200 nurses, over 22,000 hours. And all I would ask you to focus on is the upper right-hand corner, the 20% of their shift they have left for direct patient care. And in my mind, this reinforces that the quality of that communication has got to be critically made to the patient's maximal value. And bringing their voice into the process will allow us to do that. But also it reinforces that this affects all providers along the care trajectory that the patient interacts with. I promised you 3 fundamental lessons. This is the first. The first lesson we learned is that we're at a critical nexus in medicine. We're in a nexus between a guideline-centric approach to patient care or a patient-centric approach to patient care. And for the majority of acute care encounters, patients place a premium on morbidity and mortality, and in general, there is not a conflict. Having noted that, I think all of us are aware that individual accommodations are becoming a more prominent feature of that patient-provider compact as we move forward. And this is the second fundamental lesson we learned, and in my mind, it's the most important slide in my series. And that is that patients perceive quality differently than we do. For patients, they assume quality is clearly a part of the compact when they enter the room. For most patients, quality, in our mind, is not hand hygiene. It's not DVT, post-procedure DVT rates. It's not post-operative infection rates. For most patients, their assuming quality occurs when they enter the room. What they differentiate and focus on are the extrinsic factors we often can't control that center on communication and the quality of that communication. And the one thing we've learned is that PFACs allow us to bring policies and procedures to the fore that enhance and improve that. So the IFCC talks about the 4 domains of patient-centered care. Here we found it more useful when talking to patients to focus on geographic domains. I wanted to walk you through those and show you some thought examples of each. The first geographic domain we focus on is the level of the patient and provider, that intimacy of the encounter. I think all of us can think of patients we've seen who have moderate hypertension, who opt to delay medical treatment to try lifestyle intervention for another 6 months or a year. Or a patient with atrial fibrillation who has a low stroke risk, yet still opts for Coumadin as opposed to aspirin. Both of those patients have made choices that are divergent from guidelines, but consistent with their own values. The second geographic domain is the level of family and friends, and Maureen alluded to this in her presentation, and there are multiple studies that have shown this, that empowering patients and their families to ask, have you washed your hands, can increase hand hygiene up to 50%. The third, and I think this geographic domain probably reflects the one that PFACs have had the most utility, is at the level of institutional policy and procedure. And I want to share one story from the clinic, and it focuses on diamond depression. And for those of you who aren't familiar, diamond depression is a pragmatic tool that has been shown to improve depression remission rates. A depressed patient is assigned a care manager, not a care provider, who calls on schedule to monitor compliance and side effects. And this is someone who has no formal medical training. When our family medicine practice initially rolled out diamond depression, they had an enrollment rate of around 33%. So they went back to their PFAC and said, what can we do to improve enrollment and engagement? The PFAC suggested 3 simple interventions. First, the program be introduced as standard of care. Second, the patient's physician introduced the care manager directly. And third, that the patient be provided with clear education as to the care manager's role. These were not massive policy procedure alterations. They just reflected the patient's perspective and how this should be engaged. And by doing so, they were able to increase enrollment to 97%, and now our family medicine clinic leads the state in depression remission rates. And the fourth geographic level is the level of national healthcare policy. And I think all of us realize that partnership with all stakeholders is critical to designing an ideal healthcare system as we move forward. Now, what I want to reinforce for those of you who do not currently have a PFAC or utilize them, I want to go through some of the construct and how it's applied pragmatically. A PFAC, again, is it's an advisory council. It doesn't direct policy. It provides content review and creation regarding policies and procedures that focus on healthcare. They meet on a schedule. They're agenda-driven. They have defined terms of services. And they're here to confidentially requirements as defined by volunteer services. It's made up of present and former patients who are currently not in acute care. We ask they step out if they're acutely ill so they can focus on recovery. They have the capacity to contribute while not seeking a personal or a solitary agenda. We've initially found it's useful to have a closed recruitment strategy with clear screening, orientation, and training policies, and clearly articulated expectations. And frankly, the last is the most important. The most common reason that I've seen for early PFAC failure is inopportune expectations on the part of the patients who are engaged. The critical elements, and you'll hear this over and over again, leadership engagement, a clear strategic vision, involvement of patients and families at multiple care levels, and I always stress to be wary of the myth of partnership. We've worked with many divisions and departments internally who feel they've partnered or have transparency because they have patients on an IRB or do a focus group or have done one in the past. That's not true partnership in the sense that we're discussing. The final fundamental lesson, and this is a critical concept that I think is important for us all to be aware of. The core concepts involved in patient-centered care and PFAC as an application to achieve that are part of who all of us are. They're an integral part of all healthcare institutions. The shift that we're talking about centers on partnering with patients as trained advisors. That truly is the only shift that we're advising. And I want to close with 3 action steps, and this is something that I challenge all divisions that I present to internally. The action steps are: 1, leadership should identify and provide training for a patient liaison. That liaison should be assigned to engage providers to participate. Doing so garners credibility with the patients who serve. And then the liaison recruits, orients, and trains patient advisors. And truly, these key action steps are all we need to incorporate to begin to have PFACs be an active part of our practice. I'll close with the main reason that I've become involved in this. In my mind, patient-centered care is the care we'd want our patients and our families and ourselves to truly receive. Thank you.
Farris, thank you. Really good job and great working through it. We will be putting up a poll during the reactor period to invite all of the attendees to give us your vote as to whether you'd like a deeper dive and a much more interactive sort of dialogue about the actions that these great speakers have undertaken. This is, again, an environmental scan, and you really bridged it, Farris, and I know I always remember that, the big aha you shared with me as we wrote the chapter together on patient and family engagement about visioning and about how important it was to really be listening to the patients and families and you've done a great job at that, and great lessons learned. Thank you very much. I'd like to shift now to our next speaker, and Dr. Bart Hill, and talk about an earlier stage in the journey, and that is the partnership that Bart has undertaken with Sue Sheridan, who will speak right after him, in Boise, Idaho, at St. Luke's. And again, Bart and Sue were both characters in our Chasing Zero documentary, and had a wonderful healing moment of Sue coming together with Bart. Bart, take it away.
Chuck, thank you so much. I just want to share a little bit of our early journey that we are on towards patient engagement. And it needs a framework, a foundation, and that began more than a decade ago when a patient suffered tragic harm while receiving care at our organization. And after more than a decade of an adversarial relationship between my organization and the family member, we have started to come together. And it's from that desire to create a future that is safer and better for our patients and families that we're on a journey to create a patient and family safety and partnership council. Just a little background about St. Luke's Health System. We're a regional not-for-profit health system in southwest Idaho. We have 5 hospitals. These 5 hospitals are in a geographic region, and I'm centered at St. Luke's Boise, which is the Tertiary Care Referral Center in Boise, Idaho. Our journey has been about 8 months in the making. I'm showing you the group that is the project group that is putting this idea together. And the key point to take away from this slide is that it has one of our board members, who is the Board Quality Committee Chair, as an active member, who's been on site visits to Rochester, Mayo, speaking with Farris and the gracious host that they were in helping us to understand their experience. Other members have gone to Lucille Packard's Children's Hospital in Stanford, Spectrum Health in Grand Rapids, and we've had phone calls with Saul Weingart at Dana-Farber, and as well as Evergreen Hospital. You'll also see that Sue Sheridan has been an active member, incorporating a family member in the creation of our proposal. Maureen ended her slide with the quote, "Nothing about me without me," and we're starting it. This is the slide deck that we have used in presentations to our boards, both at a site level and at a system level, to gain approval to continue moving forward in developing this idea. We've developed a mission for our councils, and our councils will be primarily focused on patient safety and the quality of their experience. This is a little bit of a deviation from what we have noticed with many councils who often evolve to this, but we would like to jumpstart and really put the focus on safety and quality, and we're going to achieve it through a partnership. And as Farris mentioned, not the myth of partnership, but the true partnership. Our board is truly leading. In their strategic plan, they have set a very clear expectation that we have a Patient Family Safety Council initiated before the end of our fiscal year in 2011. And we've come forward with a concept and a proposal, and we've been given walking papers to now come back with the details behind it. Many of these councils have been formed for various reasons. As Dr. Tamimi indicated, their motivation may have initially been around patient satisfactions. Others that we've noticed have been from significant events. Others to achieve true patient and family-centered care. We're going to take a little bit of a different route and see if we can truly create it around safety and quality. We have some background already with 3 existing patient-family advisory councils. 2 exist at our tertiary care center, and 1 exists at a community hospital that's 200 miles away. So a little bit of background foundation that we can build from, but one of the advantages is our vision is large and we don't have to change direction of a major ship. We're in the process of creating our vision, and as you see, our first point is an aim for zero harm to patients. There are other values and benefits of these councils, truly becoming patient-centered. Our system CEO has challenged us that he has yet to see an organization that truly has achieved patient-centeredness. We also acknowledge that if we're going to transform healthcare, which is part of our vision, we can't do that without the patient truly partnering with us, and we must have effective integration in the healthcare continuum. We have some desired outcomes, and I think this is still a huge area of opportunity. You'll see later one of the identified barriers is The clinicians, this is a new concept and is sometimes threatening to them. What would help drive that cultural transformation is if we had objective measures that they could relate to, such as that this truly drives a decrease in your mortality, or it truly reduces the cost of care. As we have been searching for those kind of metrics, we're still struggling to find them, and we sense that we may be able to start showing some of those outcomes that we think will help engage a number of our clinicians into this idea. We have a scope and structure that we are putting together, and clearly it's going to address projects, issues, and opportunities first and foremost identified by the patients and families. But there's also the opportunity that the organization can take advantage of policies and procedures that they are putting in place. But ultimately, as Dr. Tamimi is indicating, you cannot make decisions if you don't have the patient's voice at that table. We envision that this will be multiple health systems, multiple councils across our health system, because we are geographically spread out. And at the tertiary care center, we will have probably councils within service lines. And yet there needs to be some coordination. Each council needs to be uniquely defined and clearly needs to be supported with resources. One of the values of having visited what we identified as best practices is to learn from what has made them so successful and to find out if they could do it over again, what would they add that they missed the first go round. We envision that the councils will typically be 10 to 20 members and must have a majority of patients and families. It can't be successful without the leadership, and that's the leadership from the top with CEO and board members both supporting and participating. We've modeled this potential structure that we are driving towards after what we noticed in Spectrum Health in Grand Rapids, Michigan. We think that they've been tremendously successful in creating that integration of the various councils that they have across multiple sites and within their multiple different service lines. As you notice, it has a central executive council, and this council would really be the one that deals with questions and issues that impact patients no matter where they receive care within the health system. And yet we truly acknowledge that culture is local and that there will be the need for multiple different councils at the service line in the Children's Hospital, in the Cancer Center, and at a rural critical access hospital in the rural community. We've taken a stab at what we anticipate the resources required because we will not go forward without adequate support. We've identified that there are a number of strengths that we currently have present, and there are other potential strengths that would be valuable if you take on the journey of creating such a council. Having a number of existing councils is a strength, staff that are extremely passionate about this concept, the fact that we have significant physician integration, they are more aligned to us today than they would have been 3 to 5 years ago, and that we have tremendous support at multiple different levels of our organizations. We're excited that we have the opportunity to really customize and create an idea from inception and not have to try to redirect something that is deeply entrenched and already rooted in our culture. We have some potential barriers, and the biggest one, in my opinion, is the lack of understanding and knowledge about the councils, especially from our clinical staff. So this will be something that we will have to spend a tremendous amount of time and attention, but we do have the support from our leadership, having already received the engagement from both our site and our system boards that this is the right direction and we need to be heading that way. We have some next steps. The basic one is that in the next 60 days we are to bring back the specific operational and logistical details of what it would require to roll out not only a single council, but one that would be appropriate for our whole health system, and ultimately to have this implemented by the 1st of September in 2011. In closing, Chuck, the opportunity around patient engagement and with these councils is unlimited, the need is critical, and the journey is both exciting and it's mandatory. Thank you.
Well, Bart, thank you so much. And, I think that, you all are accomplishing something I think truly heroic, because the elephant in the room for all of the QIO leaders, hospital leaders, safety leaders is, it sounds great to have a patient safety and family an advocacy board and a program, but it is very, very frightening. This is something that really takes courage, and especially it takes courage to do it and partner with a family member of someone who is in your own community and for which there is a history. And so we just compliment you for the courage of St. Luke's and really showing great national leadership, which is really what you and Sue mentioned in the Chasing Zero documentary. And I think all of us, as we get to the Q&A period, the elephant in the room is, how do you get started and how do you overcome the fear? And we just want to thank you for doing that. And as I close on the word fear, I come to the word courage, and that is that there is no more courageous champion for patient safety than Sue Sheridan. And she constantly, on a daily and weekly and monthly and every weekend that I talk with her, and what she does for the World Health Organization and what she does for other hospitals, relives experiences that she has had with two events in her family, and yet she brings such positivity and warmth and love to our providers. And Sue, we just want to thank you so much for sharing a few minutes of your thoughts and graciously turning over the presentation regarding St. Luke's to Bart, which just shows your servant leadership. But could you just share a couple of thoughts before we start with our reactor panel?
Oh, absolutely. And Chuck, thank you for that introduction, and thanks for everybody for participating in this. Patient engagement, the topic of patient engagement is a relatively new topic. I'm delighted to hear that CMS is going to be focusing on this. It's something that I obviously believe in wholeheartedly, simply because I've witnessed two significant systems failures in my family. For those of you who don't know me, my son suffered brain damage from his newborn jaundice, and now has significant cerebral palsy and other neurologic challenges. And my husband, Pat, died 9 years ago from a tumor that was diagnosed properly, but it was, the cancer was never communicated to the neurosurgeon or to us. So when he was 45 years old, passed away from a simple failure to communicate a malignant pathology. So I had a chance to kind of sit back and look back into the system and ask myself, as a patient, how could I have been more engaged? And so since then, I've had the remarkable journey and honor of partnering with a variety of hospitals and our healthcare agencies and our regulators and our accreditors, and a few examples of patient engagement to give some examples outside of the Patient Safety Council that Bart just described. You know, I got involved with other moms who were successful in changing the standard of care in partnership with the Joint Commission and NIH and HRSA and AHRQ and CDC. We partnered together to change the standard of care for a universal bilirubin test, so now all babies are getting their jaundice tested. That is kind of a macro level of patient engagement at the very high level of policy making. I've also been involved with an organization called Consumers Advancing Patient Safety, where we do a variety of patient engagement projects with hospitals, with healthcare systems. One that to underscore was a medication reconciliation project that what we did with Aurora, helped Aurora healthcare system create a community council, and then that council helped create a new medication reconciliation process that improved their process measurements by 30%. And like Chuck mentioned, I've had the great honor of leading a group at WHO called Patients for Patient Safety. And WHO believes that one of the greatest untapped resources in transforming our healthcare system is the patient. And so what they've done is infuse patients from all over the world into their programs on research. We help them create solutions. We survey patients. Our patients help disseminate. We have patients involved in technology projects and patient safety curriculum development projects. Our patients author, they publish, they work with accreditors, and they also work very strongly in their countries with hospitals and governments at a very high level with boards and leadership. But having had this opportunity to engage in and witness successful patient engagement projects, it made me aware that I wasn't doing that in my own backyard in Boise, Idaho. And that's what led to going back to St. Luke's and meeting with Bart. And Bart and I would be happy to talk about how we did that. But we both agreed that our energy and our passion to do what was right for our patients and the community, what was our driving force. And that led the two of us into our first meeting, that was 3 hours, just envisioning a new kind of council that drove safety. You know, it was the kind of safety that I wanted to see as a mom and a widow, driven in a hospital in partnership with all of their other hospitals and all of their service lines. So I won't, if there's questions, I'll be happy to entertain them, but it's, you know, I am absolutely passionate about patient engagement. I'm absolutely convinced that working together we can make a much more significant improvement in safety than we have in the past 10 years. Thank you.
Thank you, Sue. We really appreciate it. We're now going to go to our reactor panel, and I'm going to have the TMIT staff leadership put a poll up. And during the time when we have the reactors and during our Q&A period for the next 30 minutes or so, we are going to ask that the attendees of this webinar give us the answers to questions regarding whether you'd like a deeper dive on this subject. I can tell from the questions that we have that questions are being asked regarding tools, job descriptions, typical FAQs, frequently asked questions that would want to ask about such programs. And what we'd like to do is pull this audience and say, if you like these speakers, which have all been terrific, and now we'll go to our reactors, and you'd like a deeper dive in, let's say, 2 webinars that could be given that could be highly interactive with tools, create a portal for best practices and at least a linkage to where the other best practices live that could be part of an interactive set of 2 webinars. We'd like to hear from you because these are expensive to put on, and we'd like to make sure that we're meeting a need and that you just haven't been satisfied by the sampler meal, but maybe a deep dive meal into the real specifics of starting a program. How do you overcome the challenges? How do you make the pitch? What kind of structures, options do you have, and those kinds of things. I'd like to turn to, so I'd like for as many people as possible to respond to the poll in the lower right-hand corner of the webinar page. And I'd like to turn to Mike Henderson, the Chief Quality Officer of the Cleveland Clinic, a real global champion for patient safety, and have you, Mike, react to what you've heard this morning and give us a little insight as to the Cleveland Clinic for a couple minutes and then be available for Q&A before we move to Jonathan. Mike?
Yeah, thanks a lot, Chuck. I would like to applaud all of your presenters and thank you for pulling such a great discussion together. Clearly, this is critical. A few words have stuck out to me as I listened to all of them. This discussion between proactive and reactive, I think, is critical, and clearly much more moving to the proactive side of how can we prevent things happening rather than having to react when things have gone wrong. And I think that is one of the critical issues here. I have a comment to add, I think, around engagement of the medical team. We've had a lot of emphasis around board engagement, about leadership engagement. I think really critical in all this is the frontline engagement. I'm not sure we hear enough about that yet in a lot of the discussions. The nurses play a critical role. Other frontline members of the care team play a critical role. And certainly one of the things that we're paying a lot of attention to at the Cleveland Clinic is employee engagement. And how do you start to really tie that with things like patient satisfaction surveys, like cultures of safety? How do you really bring all these pieces together? So I would add that as another component that I think really needs to be part of that full spectrum. The final word I heard really was around the patient empowerment and involving patients in all of these activities. Certainly a lot of what we heard was this proactive upfront component, but I think it is incumbent on every major center to be thinking actively in terms of disclosure, discussions, communications, and again, that came up very appropriately, that it is all about the communications at each of these levels. Again, fantastic speakers, and I'm interested to hear any further questions.
Thanks, Mike. Really appreciate it, and the commitment of the clinic. And I know you have upcoming quality meetings, national meetings that you'll be holding as kind of an outreach to this community as well. I'd like to move to Jonathan Sugarman, our CEO, President and CEO of Qualis Health, representing the QIO leadership view. And Jonathan, can you give us your perspective, practically speaking? You're being charged as QIOs and leaders of ERSD leaders to reach out and start the conversation with those you work with. It's a daunting challenge, and I'd like to get your perspective.
Well, thanks, Chuck, and thanks for the opportunity to reflect on these really compelling presentations we've heard from today's panelists on behalf of QIOs and others such as ESRD networks. This really stimulated lots of ideas and thoughts in me. In the 2 minutes, I can only bullet item them, and I'll talk about 6 points really quickly. In response to the question, what resources do organizations that hold Medicare QIO contracts have that might contribute to our ability to facilitate engagement, activation, and partnership with patients and families in improving quality and safety? The first thing I'll observe is that all organizations that hold Medicare QIO contracts have beneficiary board members, and I think that's a nice structural platform for us to build on and allows us to think a little bit about how to best engage those beneficiary board members in this work. The second thing is, as Moody Williams mentioned at the beginning, QIOs currently have access to patients and families who have been concerned enough about their care to seek assistance in the form of beneficiary complaints, many times after unsuccessful attempts at resolution with providers and practitioners. Most of our work now focuses on resolving disputes and encouraging providers to improve. I think there's certainly an opportunity for us to not only use the insights from these individuals into how we can improve care, but really to coach and mentor them into ways in which they can more directly engage with the facilities about whom they've had complaints to participate in quality and safety improvement activities. This would be a departure, I think, from our current processes and would certainly require the support of CMS, but it's a resource that we could use. Thirdly, QIOs have broad knowledge of local resources who could facilitate this. We've heard a lot from innovator and early adopter organizations. That does not characterize all organizations who provide health care in the country. We have the opportunity through our educational pulpits, bully pulpits, to stimulate this in others. So, for instance, Sue Sheridan has spoken at conferences sponsored by Qualis Health in the past, and actually she's going to be doing so in a month at a similar conference sponsored by us and by St. Luke's and another hospital in Boise, St. L's. Fourth, we have access to the CAHPS surveys for hospitals, which reflect patient experience, and have the analytic skills, I think, to work with outlier organizations and others in order to encourage them to really focus more on patient engagement in quality and safety activities. The fifth thing is that although several people mentioned the care transitions work that some, I think it's 14 QIOs have done in this contract cycle, I know it's the case that many organizations have deeply involved patients from the beginning in the facilities and organizations with whom they're working. And in fact, Chuck, I can provide some links to videos that we produced in collaboration with our partners in Bellingham, Washington, and St. Joseph's Hospital, which show in great detail how patients have been involved in these activities in a number of ways. Finally, I think many organizations that hold QIO contracts and also do other non-QIO work. We've been talking mostly about the hospitals, but many of us do things related to care delivered in the outpatient setting as well. Just for instance, last week, Qualis Health hosted 250 people who are participating in the Safety Net Medical Home Initiative, which is a 5-year Commonwealth Fund project that we lead that aims to support 65 practices in 5 states, accelerate medical home transformation. And I'll close by saying that one of the most powerful parts of that summit was a panel of 3 health center patients who shared their experiences, both good and not so good, with the care system, as well as their efforts in engaging with those systems to do quality improvement in the outpatient setting as well. So in summary, I think that organizations that hold Medicare QIO contracts are really well positioned to support greater patient and family engagement, improving quality and safety. And we really hope that our ability to conduct that work is enhanced in the next contract cycle, the 10th Statement of Work, and that it encourages innovation and flexibility among QIOs to do this very important work. Thanks.
Terrific. Thank you so much, Jonathan. I think your perspective is terrific, and any resources that you'd like to help provide that we could then post and then links we will put on our website, and we'll ask Kyle and Laura of the TMIT team to effect that. I'd like to move to Reggie Holliday, who's a terrific patient safety champion. She has given testimony to Congress regarding health information technology. Has been tireless in her championship, as Sue has and as Steve has, to turn a bad experience into the positive to help others. Regina, your reaction to what you've heard?
Well, this was just spectacular. I loved hearing so many people had so many brilliant ideas about how to incorporate patients at the table. And my takeaways are often visual takeaways. So one of the ones is I just was at Bellin Health just last week, and they involve patients in every step of many procedures, including implementation of health information technology and EMR systems. And how they identify the patient in the room is they put a balloon, a helium balloon in front of that patient with a happy face. And so everybody in the room can see who the patient is and know there's a patient present, and that person can be part of the entire dialogue, which I thought was really cool. And having worked in a toy store for many years, I know that when you take helium balloons out into the cold, what happens is they deflate. So my point being that I love what one of the speakers said is that you have to have not just one patient. You have to make almost a majority. There has to be a lot of them to create a culture change, because when you just have the one patient in the room, yes, they will do a lot and they will do their best, but you're putting one person within a culture and you're going to get a deflating balloon if that's all you do. But if you bring a whole bunch of people and so many different views to so many different processes, that's amazing. And the second thing, I love the comments made about how moving the beds that Maureen threw out, how that was an engagement activity. Moving the beds through the wing was an engagement activity. The patients helped, the nurses helped. It became part of rounds. It became a process, because one of the number one things within this entire system is there's an amazing group of people who will help. Patients, family, caregivers. We will help if we're just brought into the entire design process. And then we don't feel left out, and we don't feel like there's nothing that we can do. And when you put up those statements and signs that say you have permission to ask questions, you have permission to find out if things are going correctly, if you involve us in actual care, then it's so much easier to ask questions when the time has come. So those would be my two major takeaways from this amazing discussion.
Great. I'm going to open up our Q&A and then have Steve make any comments he'd like. We'll let him close us, because we always begin with the patient and families, and have Steve react, as well as making his closing statement after we address some of the questions that have been addressed. And as I screen some of the questions, Dr. Tamimi, one of the questions that we are frequently asked is, how do you select, or how do you begin the approach of inviting patients and families in, and how do you make the selection process? And the second thing, and the reason I come to you first, is that Reggie talked about having lots of patients, and I remember vividly shooting video at Rochester of you having a large room with many patients all contributing to the dialogue. Can you maybe address the selection process first, and then your experience when you bring a larger group together?
Absolutely. I think what we found has been the most effective is to use a closed recruitment strategy for new PFACs. So pragmatically, we'll send an email to all the care providers in a division, ask them to provide the name of patients who are currently not in acute care. In general, if they're in acute care, they need to focus on recovery, who are reasonably articulate, have the capacity to share a story. If they've had experiences that have gone poorly, can either articulate resolution or articulate a way to move past that as a part of the sharing process, and are not seeking a solitary agenda. And those are the four pragmatic tools, criteria we use to try to identify a pool. From that pool, we normally suggest a brief telephone screening process. And in general, all you're conveying is, this is a PFAC, this is the construct, these are the goals and the opportunities. And over the 15-minute conversation, you can identify readily the patients who have the capacity to share and those that don't. Then they're brought in for more formal training, which in large part centers on the nature of a PFAC. And I'll stress this again, it is critical that expectations be aptly defined beforehand. The most common reason that I've seen for early PFAC failure is when the PFAC members are not told clearly what their role in the process is. And at any major medical center, no one controls everything, and we're all here to provide input but not provide guidance. Getting back to the ratio issue you alluded to later, we found that in general that the early ratios, no more than 1/3 staff to 2/3 patients, but as the PFAC is more established, you need to diminish that aggressively to have a minority of staff and a majority of patients. They can share more honestly and more directly when they're in the majority. And to be frank, they're less intimidated by care providers and administrative staff. The final thing I'll tell you is, getting back to the orientation process, in an established PFAC, they'll train their own members. So it's not uncommon that I'll see new members brought onto a PFAC that's well established, and in a group dynamic setting, they will explain to the patient how best to share stories, how to close, how to maintain contact, how to maintain interest, how to engage providers in a more effective fashion. And I think that's enhanced by leaving them in the majority.
Thanks so much, Farris. One of the things that TMIT will be embarking on this year is a program to really undertake a deep dive on two categories of patients. One category are those that have had a recent event, and I know that Sue and Steve and Reggie can all relate to this, that we really go through the Kubler-Ross stages of grief. And as a radiation oncologist, where a majority of my practice was, half of it was treating for patients for cure, the other half for palliation, that seeing the stages of grief are very profound. Everybody goes through them. Some people, it takes longer, and others, it doesn't. You know, we go through our denial and our anger and our depression and our acceptance, and we go through these stages. And what we found is that many patients that get involved in the safety movement or want to get involved in a hospital are still fresh after their experience, and really need to go through the stages so that initially they have to go through the catharsis of telling their story and really go through these stages to then really be prepared to then be able to handle the challenges of the interactive dialogue that might occur in bucket 2. And bucket 2 might be champions for safety and quality that might be caregivers who haven't had a bad event, or those that have gone through those stages. Just, I'd like to maybe go back, just finish up with you, Farris, and then to Maureen. I think it sometimes can be premature to have someone soon after an event involved in a council without actually being able to get to a healing point where their energies can be really positive, and it also diffuses the potential anger and difficulties that programs can have. Is that a fair statement, Farris? And then we'll go to Maureen.
That is a very fair statement, and I think our patients articulate and realize that more aptly than we realize. For some of our patients, when they see someone who is in that kind of a crisis recovery position, they'll transition or suggest transitioning that patient from a service role to a support role. In essence, they'll either give them the opportunity to share their story offline, or they'll suggest they engage in one of the support groups we have on site. And so I think not only are we aware of that, but our patients sense that and act upon that quite readily.
Great. I'd like to go to Maureen. Your thoughts and comments on both reacting and perhaps this training process and question on how we select and prepare folks to serve on such committees and councils.
Sure. I think that we did something similar at the Dana-Farber Cancer Institute when our council was first formed back in the late 90s. And basically, clinicians were asked, social workers, physicians, nurses, who would be a good council member. I should note that the process has evolved over time to currently there is an application that any prospective council members need to complete. It's a very simple application, however. I think the key question is, why would you like to be a council member? And the original version of this, I have to almost chuckle at this. It was almost like applying to college. It was so in-depth with so many questions. But you can see how these things evolve over time. Today, there is a waiting list to become a council member. And there's information, there's literature on the council in some of our waiting rooms. One thing I'd like to stress about councils is that your council should be representative of your patient population. So if you have a patient population that's predominantly non-English speaking, you need to figure out how to bring those folks to the table and provide an interpreter for them. The patient population at the Dana-Farber, we did, the majority of patients were English speaking, so that wasn't so much of an issue. For the Pediatric Council, we wanted to have adolescents join the council, and that was a bit of a struggle over time, but I'll tell you, there's nothing like the voice of an adolescent to tell you what's going right and what's going wrong. So that was just another piece of this.
Great. Thank you, Maureen. And I've advanced the slides to the Journal of Patient Safety. It's been a real honor to take the helm of the journal from Dr. Nancy Dickey, who did a terrific job in launching the journal. And I'd just like to welcome any of the speakers or anyone in the audience that are interested in articles and expressing interest in articles to address these councils, because we will move them up in the priority because they are translational and could have huge impact, for which there aren't a lot of resources. I'd like to come back to each of the panelists and just ask, are there resources that you have found most valuable? In our questions, we've got folks asking whether job descriptions or modules or training and material might be available, and wanted to just ask Bart, perhaps start with you. Are there tools that were available that were readily accessible or that you could share that were of value to you as you begin your journey?
We were, I'd have to acknowledge Rochester Mayo, Spectrum Health, Lucille Packard. They were extremely generous with their willingness to share documents. So they gave us drafts of their applications, of their job description of their liaison, structure, examples of the reports that these councils have created at the end of the year, how they set up their annual retreats to do their strategic planning for the next year. So we have gathered a 4-inch binder of documents, and we are in the process of putting together what our job description will look like and our application and what the training will look like. And certainly we are more than happy to share anything that we have created or in the process of creating with those who are interested, because we need to pass it on and pay it forward.
So we'll pay it forward is one of our mottos. So we would love to just provide on the page for this webinar. Kyle and Laura have our web team create a repository for the assets, and we'll commit that to this audience so that there's a place to go. And we'll probably also put it on our Care Moms section of our web system. I heard a voice, but I just want to make sure if Joe was able to stay on, Paul or Jean, if they have any reactions or supportive comments or questions they'd like to ask of the panelists. I'm not sure they were able to stay on, but want to give Joe, Paul, or Jean the opportunity. I know CMS is in a very intense time of work, so I'm not surprised. Maureen, were you going to offer a comment?
Sure, I'd like to offer a comment. The Institute for Patient and Family-Centered Care has a website with a wealth of information. They have multiple samples of, policies, how to create a council, step-by-step approaches to doing much of this work. They have assessment tools that you can use if you want to just assess where your organization is at, and I could go on and on, so I won't. The other place I would suggest you go is to the Dana-Farber website, dfci.org, and they have a lot of information available as well. You can see a copy of the application to become a council member. They have bylaws for the Adult Council, and I believe they still have guidelines for the Pediatric Council, but the organization is more than willing to share this information with you. And lastly, the Massachusetts Coalition for the Prevention of Medical Errors was very supportive to hospitals throughout the Commonwealth when the state mandated that patient and family advisory councils be created by last fall. And they pull together all kinds of resources, and I think for a nominal fee, you can gain some of that, gather some of that information too.
Maureen, thank you very much. I've got a couple of questions I'll just throw out to Farris, Maureen, and also Sue and Bart. The two questions are what you've heard about the experience of such programs regarding the time commitment that is required of or is typical for such members. The second question, I'll throw three questions out. The second question is on retention. What is retention like when you've got a program, Farris, up and running, or Maureen? And then the third question is the one that I brought up earlier regarding fear. And one of our attendees of the webinar asked, how do we overcome the fear of folks in risk management that is quite natural because they live with risk every day, and to overcome that fear that they have? So I'll throw that out. And Sue, we'll come back to you and just cycle through each one of you. But the three questions, because you've had some experience interviewing organizations, is time commitment, retention, and fear. And then I'll go to Farris and then Maureen. Sue?
Well, actually, the retention piece, and I went on one site visit, but I think the retention piece at Lucille Packard where I went was they did not have a problem with that. They had members who had been on the council for 12 to 15 years. And so that I think what we saw, and Bart, correct me, a very high level of loyalty and commitment. They felt like they were important. They felt like they were doing something. In terms of fear, there is fear. It's palpable. It's unfortunate, but it's something that I think by creating these councils with patients at the table, every table, that can be a wonderful culture carrier and carry us out of this fear because it is very real. And Bart and I can speak to that personally. But it's a decision that needs to be made by leadership, that if you're going to take this important step into patient engagement and having patient councils in your hospital, it's a big decision, and once that decision is made, that the leadership needs to be behind it, 100%.
Great. Farris? So typical commitment of time by patient and family members, your experience with retention, and your experience with overcoming the fear of inviting them into the house.
Time commitment I'll do first. It varies dramatically across the institution depending on the internal culture and architecture of each division or department. But in general, it's on the order of 2 to 4 hours a month for the majority of PFACs. I would also share the time commitment needs to be recognized for the patient liaison, the physician representative as well, because without active engagement on their part, you won't have the credibility you're seeking with your patients. As far as retention, across the United States, that varies markedly. Lucille Packard pays their patient participants. Many facilities don't. What we found the most useful intervention to maintain retention is providing patients closure. So whenever anyone presents to our PFAC on any operational policy or procedure issue, they're obligated to return within 6 months to a year and provide closure. Whether they use the input or not is immaterial. The patients want to hear that their voice was heard. And the final thing I'll tell you in regarding retention is, for many of our more senior patients who seek more aggressive policy involvements, we'll have them, quote, graduate, close quote. They'll move to higher institutional involvement. They may serve on institutional subgroups or committees that are more challenging from a bureaucratic perspective. As far as fear, institutional fear is a common counter that we encounter. It reflects both the fear of transparency and the fear of committing resources. And to be frank, outcomes are the best response we can provide. Again, looking at diamond depression, Family Medicine Northwest leads the state of Minnesota in depression remission rates. Look at hand hygiene rates. Look at med reconciliation rates. I think the best way to address fear is to show these interventions improve both safety and satisfaction and provide better patient care outcomes. And that's what we're all looking for.
Great. Terrific answers. Maureen?
Sure. In terms of time commitments, council members are asked to attend a certain percent of the council meetings annually. They are also asked to be involved in a project if they are able to do so. Some council members are able to come to the evening meetings, and yet it's a challenge to get out of work or leave home during the daytime. This is particularly true for our pediatric council, where we have parents of small children. In terms of retention, for the adult council, I don't think it has been much of a problem. And in fact, we have different categories of council membership because we have term limits of 3 years. we want the patient and family members on the councils to be representative of what's really happening in the organization. So we wouldn't want someone who's a council member for 10 years being, an active member of the council. However, there is a category for those council members who have been committed to the organization, who want to attend council meetings. They are welcome to do so, but they are no longer voting members. Fear. Go ahead. Yep.
Go ahead.
I was just going to address fear. Fear is very real, and I think that this type of work calls for courageous leadership, and I think there's no other way to state it. When you come up against barriers within your organization, when key decisions need to be made, for example, when it was decided to permit patient and family advisory council members to sit on our board quality committee, that was a key decision made by leadership. They supported it, and they made a clear statement that this is the way it's going to be. So to me, that's the only way to get around fear at the highest level. And then, of course, you need to educate your staff. You cannot just throw a person on a committee without ensuring that that person will be welcome, the input would be welcome, and that the staff have been prepared. So there's a key role for education.
Thank you so much. We're just 5 minutes over, so I will, if Jonathan is still on and Reggie, just ask Jonathan and Reggie if there's one thing we could do if we do go with a series on these councils and do a couple of additional webinars. What would be one thing that would be an unmet need we could meet with those? Jonathan.
So I think from the perspective of QIOs, and this may go for ESRD networks as well, because we are outside organizations, we're not the care delivery organizations themselves, our goal would be to influence hospitals and other institutions to engage patients and families in quality and safety efforts. So specific evidence or data about how best to do that influence from our perspective would be very helpful. I think there's a plethora of information about how facilities will do it once they're committed to it. Our idea, I think one role we have is potentially to build will, for instance, to address the fear and risk factors that were just discussed. So techniques for external organizations to facilitate this kind of change, I think, would be very helpful.
Great. Reggie?
My thing, what I would like to add is that before we do this again, and this was amazing, we must do this again, is we need to spread this much larger and much bigger. We need to have a Twitter hashtag so we can have a tweet stream about this. I don't know about the other people on this call, but I've been getting messages via Facebook and Twitter while participating about what we're talking about. And so we need to open this up to way more people that are currently involved, because everywhere I go across the United States, people are asking these kind of questions, and they're desperate for guidance and leadership and to be shown systems and facilities where they're making this work. And this has just absolutely been spectacular, because I'm hearing wonderful things to bring out the next time I go out and speak publicly. So this is possible. We can do this, and it can change everything.
Great. Thank you very much. Well, listen, I'd like to close this webinar with Steve Rell. Steve, your reaction to what you've heard, and close us, please, and we'll consider the webinar finished. And those that can stay on as speakers, we always want to see what we could do better next time, and we'll just keep them for a few minutes just after, but just stay on the line afterwards. And I'd like to thank everyone. What a terrific webinar. As always, people can't believe that we have such wonderful, talented folks, and as many as we have, but you all really packed a lot of really good material in, and we really thank you so much. We're very, very grateful. We're grateful to the CMS leaders for, again, taking the time at a really intense period to exhibit their interest in patients and families. And I'd like to ask Steve to close us and ask the speakers just to stay on for a couple of minutes once we go off of the public line. Steve Rell?
Yeah, thank you, Chuck. I feel that it's so important that we involve patients and families in all aspects of healthcare. The facility where my son's life was lost had policies in place, but they weren't followed. And how could a whole team have failed? As we as patient safety advocates must demand that hospital board, chairs, and providers invite patients and family to make sure that hospitals follow their safety measures and to help make new safeguards to ensure that zero patients are harmed or die from preventable medical error. I would just like to close with to let you know that, Braxton is smiling down on all of us, and he had the biggest smile that could light up any room, and that you may feel the Braxton breeze. And thank you all, and may you all go in peace.
Thank you very much, and we wish you all well, and our hope is that the audience will really want to have an additional set of webinars, because we believe that this is critical. I'd like to, as the Editor-in-Chief of the Journal of Patient Safety, encourage all our speakers and those that are listening to consider submitting articles or best practices for formal peer review publications. It's the only way we'll push the science forward. Thank you again, and we'll close the webinar.